again, Dr. Nick Quest will be moderating the live case as well as the keynote lecture by Shamim Sharma. And Shamim Sharma does not require any introduction to this crowd. He's well known to all the intervention cardiologists here. He's a great teacher, good intervention cardiologist. We have learned a lot of things from him for so many decades there. And with this few words, I think we'll just go on to Mount Sinai without wasting time into the live case, and then we'll have again a discussion at the end of the live case here. Over to Mount Sinai, please.
Okay, guys, we need to go live.
Oh, good morning, Dr. Sharma.
Okay. Yes.
Hello, how are you doing?
Good. Dr. West and Dr. Salmani, welcome and greetings from Mount Sinai Medical Center. Morning, I know many places, afternoon and evening. Hello. And we have enjoyed this 1 hour of discussion. Can you hear us well?
Yeah, yes, sure. We can hear you, Shamim, sir. And it's good evening here and it's good morning for you there.
Yes. And with me, my director of the cath lab, Dr. Annapurna Kini on the left side. And we have our fellow Amit Huda, who has come from India for 1 to 2 years of training. And of course, we have other fellows with us. So we are following the same imaging guided PCI. So that will be our focus this morning to show you a case and incorporate the imaging in decision making of the intervention. So just to say, we want to just show the slide quickly, please. So no, the slide has to come on the more. This cannot be seen.
Okay, make the full screen.
Slide, we need to bring it on the main screen. Yeah, good. So just to say that this is a case, is a 55-year-old male. He presented with an acute coronary syndrome, non-STEMI, and heart failure with a high troponin of 2.2, BNP of 674, and was managed medically outside hospital, and cardiac cath revealed 3-vessel disease and EF of 20%. Mind that this patient didn't have much cardiac history before, and then subsequent testings for the viability and all showed a lot of viable myocardium. Patient was referred for cabbage, but after heart team discussion was decided for intervention. So we can go to the meat of the case, and that is the video. We can start with a fluoro. This is with the ventriculogram.
Show the angio. So this is the LV gram. EDP was about 16, well optimized on the diuretics. About 20, and then
video missing. Yeah. So this is the right coronary, had a PDA lesion about 60%, but more complex lesions were on the left side. This is the, yeah, say it, yeah.
We can see the calcium in the OM1 in a prox arc looks okay, very short left main. So the guide just gets engaged selectively into the circ first time. So, you know, moderate calcium angiographically. And then we had the LAD bifurcation lesion. So you have D1, D2, and that's where we are. So mid LAD about 95% lesion. This is how the LAD looks here.
Yeah. So just to say, maybe we can ask our other panelists. I know Praveen is on the line. I can see him, Praveen, and there are many other should be on the, I don't know who else is. Dr. Slavmani, you can tell us who else is there?
Yeah, hello, Dr. Samin. It is a pleasure to see you working and Dr. Annapurna together on this very, very interesting case of 15% ejection fraction and, of course, multi-vessel disease. And as I can see here, you have taken Impella. So may I ask you the first question, whether it is a 2.5 or a 3.5 Impella?
Yeah, so basically, yeah, you're right. So what happened is now, because of the single vascular access, as you can see, using the Impella CP, which is a 14 French, and with the same, the sheath, but has to be not the same hole. You have to make a separate puncture. So you put an Impella CP, which gives you cardiac output of between 3.5 to 4 liters, usually 3.5, and then you can put a 6 or 7 French guide. So this is where, so single access, and what has shown the single access actually decrease the vascular complication. And this is where used in this because of low ejection fraction, and this patient, and we want to fully revascularize. And this concept actually will be tried soon upcoming PROTECT 4 trial, patient with severe LV dysfunction, multivessel PCI, you do an Impella assisted PCI versus standard therapy, including balloon pump. So what we have done for the purpose, knowing that this is a complex case and we have about 35-40 minutes only, there is a tight lesion of the LAD, which you saw there earlier. We dilated and put a stent, and now to see, it's put a 3.0, a 28. Zions.
So we just do an OCT to see the full expansion. Very important in this patient, what I think Dr. Greg Stone did discuss one during DAPT, how this patient does not have any comorbidities that he has to stop DAPT at any time, but low EF is a predictor of stent thrombosis. So very important, we have to make sure that this stent is well opposed. So we're just going to do the OCT. Now, pre-OCT, as you see there, once we have a significant lesion like we saw here in the LAD, is difficult to perform OCT since there may be no dye washout. So we are going to do post right now, and we can show the OCT there on the full screen. Come closer.
Just while you're putting that down, Dr. Shan and Dr. Kimi, I'll just tell you who else is on the line. We've got Dr. Greg Stone, Dr. MS Hiramath, Dr. Ashwin Mehta, Dr. Praveen Chandra, as you saw, Dr. Ajit Mulasarai, and Dr. Thomas Alexander.
Beautiful. Okay. I'm with all that expert panel. I know this case will be done most appropriately, both angiographically and imaging wise. Fantastic. Welcome to all our great panelists there.
Good. Okay, I'm going to start now. Let it run again.
Yep.
Do the co-registration.
As I can see here, that Dr. Sharma and Dr. Kinney has not done the pre-stenting OCT. And I think it is very understandable that in a low ejection fraction, you would like to conserve contrast as much as possible because that'll be an issue here. Is it right?
Also, once the lesion is subtotal, remember, as soon as your catheter goes, you'll have a very decreased flow and you'll not get the information you need. And I would say that if truly you think about the imaging value comes in the post rather than pre. Tell us.
This is well opposed now. Yeah, start from distal. Okay, start distal and start coming pro. So distal edge looks good. We don't see. Yeah, we don't see any dissection.
Good.
Yeah, but the flap is, less than a millimeter. I will leave it alone. Keep going. Come proximal. That's the level of the diag. Yeah. It definitely is well opposed. Give us the, proximally. It's good. Okay.
You want to do, I was the OCT of her.
Now we'll go to the circumflex. Circumflex, we can do the OCT to evaluate the calcium and then make the evaluation whether we need or what kind of we need to do, right?
Yep.
So Anu and Samin, this is Greg. Hi.
Yes.
Hi.
Great. So I have 2 questions. As Samin mentioned, we're really going to test the appropriate way to revascularize these patients with PCI in the upcoming PROTECT 4 trial. So what is your strategy here? Are you looking for complete ischemic revascularization or anatomic revascularization? And 2, in that regard, it looks like there's a lot of diffuse disease in this vessel. Do you ever consider doing post-PCI physiology? You clearly treated very nicely the severe lesion. Do you ever consider doing FFR or another resting index to assess where's the physiology of the entire LAD now?
Yeah, that's a very good point. Clearly, the assessment in this particular case. Now, this patient was a non-STEMI, and I think the culprit likely was the LAD. Although there was a diffuse LV dysfunction in multi-segmental territory, it's very tough to believe this patient did not have any cardiac history before 1 month. And he comes in with the multivessel disease and ejection fraction that low. The second is we did the viability, and the viable, all myocardial segments are viable. Now, the circling is a long lesion. LAD, you can say probably hibernating, maybe the same in the LAD also. The diagonal, the PDA is only 60–70%. So coming back to your point that once we do, in this particular case, we low ejection fraction, we want to do complete revascularization, combining both angiographic as well as anatomic as well as physiological. Anatomical, once your lesion of 80+%, I think you can avoid the physiology. Usually they will be positive, but in intermediate lesion like PDA, and that will be our end result, that check it whether PDA should be revascularized or not. Second point, which is a very relevant, what do you do with the FFR or IFR post procedure, and can you optimize it? And as you remember, the latest data of the target FFR trial presented in TCT, that almost many patients will have 30–40% will have a low FFR even post procedure. But more importantly, in diffuse disease like this, it will be very tough to make it normalize, to bring it down no matter what you do, dilatation, additional stenting, and so. So let's say we are ready for this live the OCT of the circumflex. And you take over.
Okay. Okay, good.
So Greg, just to pick up on your point about post-PCI physiology, this is very tricky, isn't it? Because of course, it's unthinkable that putting that stent in the LAD would not have improved things, but whether we're going to get to levels of normality is another question. Of course, what we don't know is really what the impact of patients having, if you like, an upgrade in their FFR rather than total normalization. You probably are also aware that there are indices that are being developed to try and detect the difference between diffuse and focal, like the PPG index out of Bernard de Boyne and Carlos Collet in Aalst. But of course, they've not yet had widespread uptake.
Yeah, so there are numerous studies now that, as you know, have correlated normal but not optimal
moderate calcium
physiology, whether FFR
so we are talking
or others with increased MACE. So usually it's a cutoff of for the FFR, you'd like it to be 0.9. For the IFR, you'd like it to be 0.95. But we don't know that driving towards those levels if you don't have a perfect post-PCI FFR or IFR improves outcomes and is safe. And for that, we need randomized trials. I think it's very hard to tell angiographically if the problem is diffuse or focal. Sometimes it looks, you don't see an obvious lesion and you find it's diffuse or focal. And sometimes it looks like it's diffuse. And you may find that there are focal spots that are particularly severe. So I think you need to do the physiology if you want to assess it. But again, this is not routine yet, but it's an area.
2 quadrants.
Okay, so let's talk about this particular case in the OCT. I know a lot of expert panelists there on the OCT with the calcium point of view. Angiographically is a moderate calcium, it's not a severe. And
that's what I think we confirmed with OCT and Kiski. Just go to where the heavy calcium, you see that. Yeah. So at the most, what, 2 quadrants?
Yeah, eccentric calcium, yeah.
Yeah. So if it is within that 2 quadrant, I think those do quite well with the atherotomy technique. And if the lesion does not open up, we can always upgrade to orbital or rotational atherectomy. So if it's okay, we put a 2.75 or 3O cutting balloon.
I think we'll do a 3O cutter, right?
Okay. 3O cutting balloon. So Wolverine 3O.
Can I ask the panel about comments on calcium modification? Would someone from the panel like to give us a comment on what they would do here?
Would they do atherectomy? That's another question. Yeah.
This is the right approach. I think that when you've got calcium, that's it depends on the circumferential extent, the depth, and the length. And, you know, when you've got less than 270 degree calcium, especially 180 degrees or less, and less than 5 millimeters long and less than 3 millimeters deep, or 0.5 millimeters in thickness, then it usually will dilate fine. And that was, you know, from the work that we've published. So I think this is a case that should dilate very nicely. And I think using a cutting or scoring balloon is a very reasonable approach. In the future, you know, I think if we had intravascular lithotripsy, we may change our threshold to do somewhat more plaque modification. But of course, there it also takes some time for lithotripsy for the balloon to be inflated. In this case, with impella support, that wouldn't be a problem. So, but, you know, lithotripsy is not yet on the market in the United States. So this is, in my opinion, the right approach to this lesion.
And another problem with lithotripsy that you see is that eccentric calcium doesn't work well with lithotripsy.
Okay.
We probably believe that's the truth. We need more data to really cement that. But you're right. There certainly have been some anecdotal reports that have suggested that.
So nowadays in India, we have the ultra high pressure balloons, OPN balloons, which
OPN balloon,
50 atmospheres. And many times we actually use them in these particular situations, and it works reasonably well. We go up to 30, 35.
Well, yeah, I mean, that balloon
expanded everything.
40 atmospheres and will open up most
Do we
things.
put a regular balloon again?
So you know, it's always a question is whether cutting or scoring balloons, which also can go to high pressure, they can go to 20 atmospheres, you know, whether by having those cuts improves the compliance above and beyond a regular balloon. I think it probably does.
The problem is it's one of those almost untestable things. It's like rotablation against conventional angioplasty. The problem is all the studies suffer from such selection bias. You can never really make.
You're on 38, no?
There's a clear benefit.
38.
Dr. Stone, what happens if you use a cutting balloon and you are not happy with the subsequent balloon expansion? Do we go in with?
You can always you can always upgrade to the rotational atherectomy and or you know orbital. Although those cases we have not done orbital, but definitely you can upgrade as long as it's not a spiral dissection. Even there is a little bit of flap, will not be a problem with the rotational atherectomy.
Yeah, Samin's absolutely right. Also with orbital, as long as you don't have a severe, very deep spiral dissection, it's always fine. You can always do atherectomy. You could do intravascular lithotripsy, or depending on the size of the vessel, this is where imaging helps, you can use a larger cutting or scoring balloon, or at higher pressure.
Okay, so we are going now with the trio.
We are doing a trio 38, Zion stent again. Good.
But as you say, it's very important to make sure that you get complete balloon expansion before you put the stent in. More and more we're seeing cases of unexpanded stents, and they're much harder to deal with once they're not expanded and they're in place.
Actually, I'm going to show 2 cases of those unexpanded stent in my presentation later. That's what they wanted to know, what to do with these kind of cases. But yeah, that is very common. And now we have the Zion Sierra. I know in India it's not available for various regions, but this is a 38 Zion Sierra, which is the latest design. Of course, they are going to come with a newer.
So, I mean, would you have imaged now before you put the stent, or you're pretty confident that you'll get the stent well expanded now?
So it's a very good point. So key is, since we saw the stent nicely expanded, I think it was, sorry, the cutting balloon nicely expanded, Wolverine. Okay. So we just find angiographically, and we know also that we are done pre. It's not a circular calcium, which is going to give us trouble. So I think it's a reasonable that angiographically we saw the atherotomy or balloon nicely expanded. So we're putting a stent, and of course now we'll optimize with the trio. We already have a trio balloon.
Yeah.
Trio 20.
Let's see angiographically.
Yeah. Should always routinely post-dilate these with a non-compliant balloon.
Routinely. Absolutely. Yeah.
Ready?
Maybe 5% of the time the imaging will look fine, but just don't even bother. Just always
dilate.
No matter how good it looks angiographically.
Now, you want to still post?
Yeah, post.
Yeah,
okay, 3 to 520.
It also illustrates the importance of pre-manipulation of the lesion during the imaging in this particular case. You can imagine that angiographically, the calcium didn't look that bad.
Yeah.
And one might have gone with a standard strategy. Then you experience that awful stent regret when you've put in something that looks like an hourglass.
See,
going back to the
go ahead, Anu.
Going back to the question that should we image in between, I think like Dr. Sharma mentioned, angiographically, I think we can make a decision here that, we did and make sure the balloon was well expanded. And then if we think the balloon is not expanded well, that's time you have a branching. You make a decision. Do you want to go to atherectomy this time or go to a larger balloon like Greg mentioned? I think that's the way it has to be to avoid multiple. So you see, every time we do OCT, we are giving extra dye. Yeah.
Arriving in 49 minutes.
Did you size the stent based on the lumen plus half, or what did you do? Because it's difficult to see the EEL with all that calcium around.
Down. I think based on what is the OCT size you are getting? See that? Yeah. You can see the measurement there, 3.1, but good. And we still go with eyeball. Yeah.
Yeah, you can't.
Eyeball.
When you've got that much diffuse calcium and fibrosis, and normally what we're doing in Illumian 4, of course, is we are looking at the reference EEL, which in 90% of the cases you can see with OCT, and making the decision that way. And we're using the EEL minus 0.25 millimeters. If you can't see the EEL, then we're confident using the lumen plus 0.25 millimeters.
How high you went here?
But of course, as Samin and
that's
Anu
good.
are so experienced, they're doing
Good.
this.
We have to do the OCT. So I don't want to take another picture now. We'll do a final OCT to see the stent expansion.
The one thing I'll say that from this lesion, and frankly, in all lesions, I actually find imaging more useful pre than post. I think if you use pre and you know how big the vessel is, you know how much calcium in there is, so you know what kind of lesion preparation you need, you know the extent of the disease, which tells you where you need to place your stents, and then you make your plan. And then frankly, if you do that, then 95% plus of the time, the post imaging will just show you did a good job. It's when you don't do pre, you find out that you undersized the stent because the vessel was much larger than you thought, or there was residual disease that you couldn't see angiographically, or something like that. So pre-imaging is very important to me, like you saw in this vessel here.
Yeah, 100% agree. But in this particular case, only since his LV dysfunction and the risk of stent thrombosis is there, although he's already on FEN and we have a good PRU. If we have imaging, I think it's good to have it post. But I think 100% imaging post we need is if we are doing left main stenting. Ready? Right? You can see it well.
The key is in these complicated cases, using imaging is critical. And you see how easy it is. And it takes all the guesswork out of what you're doing. Really, the only downside is the little bit of extra contrast. And if you use, end diastolic pressure or wedge, guided diuresis, you'll have a reasonably low rate of contrast nephropathy.
And particularly Impala will help in renal protection also in this particular case.
We believe that Impala is renal protection. Absolutely.
Yeah.
I think one interesting thing just to point out very briefly is that the ultimate 3-year data presented at TCT had a very interesting finding. Everyone says that OCT results in more contrast use. In the ultimate study, actually, use of IVUS increased contrast use over angiographic approaches alone, which is a rather surprising finding.
Well, not both. Because IVUS leads you to put in more stents. It leads you to do additional balloon inflations. But I think that it depends how you use the IVUS. If you use the IVUS and the OCT,
You did a picture?
I actually don't think it increases the contrast. Because it tells you what to do, and I think you only need it in the first time that you the very pre, and then usually the very post. So usually 2 runs is all you need. I don't think you usually need it in an iterated fashion unless you have trouble expanding balloons. balloons or something unusual is going on that you don't understand.
And that may
But
speak
Now,
to
Di-
how this was used, I think, in the ultimate study. I think it was used probably after rather than
I
necessarily
think
for
it was
previous.
used post, and then I think that leads to
no.
procedures, and that's
Oh,
why it
already.
needs contrast use.
So
Yeah.
in these,
So I think unless you are really
Sometime.
focused on that, I want to do most all the intervention just based on the imaging OCT or
Sometime.
IVUS, maybe less contrast, but I'm sure all the trials, even with the OCT, will show compared to angiographic in terms of the contrast use will be a little higher in the imaging group compared to the angiographic group.
so sometimes
Low mark.
Dr.
Okay,
Matthew
ready?
seems to give a talk in iOptico. The decision change was more with
kind of situation.
OCT or post usage.
So it is very much indicated here. But in India, we are very limited because of the cost of this procedure in using Impella in these kind of cases, because the relative cost of Impella is very high compared to the relative cost of intervention itself. So if we take a comparison, the cost of procedure will be about at least 1/5 or maybe 1/6 the cost of Impella itself. So sometimes, you want to do that and it's like really very difficult to use it.
Well, you
No,
see,
that is
you see how
We'll
in
show
this
the
case,
OCT now.
how
Right?
stable
You
the
want to-
patient is. They can take their time. They can do intravascular imaging. They can post-expand if they need to. So the question is, will that upfront cost be ultimately worth it in terms of reducing procedural complications and getting better long-term results because of more complete and optimal revascularization? And that's the trial that we're doing in PROTECT 4. So it looks like,
but no, yeah, that Praveen, I think that's a good point. So clearly that in India, the cost of Impella has to go down with simple or some other device, because clearly it's so prohibitive. But the use and cost point of view, now America is different. There's a separate DRG code for it. So actually there is more incentive you want to do Impella in appropriate cases. But clearly in India, because of the cost, is a big issue.
Yeah.
Okay, now let's
Shamim
show
sir.
the post OCT
Hello?
quickly.
Yeah.
Yes.
Okay. Shamim sir, it's Selvamani here.
Yes.
What do you think is the role of ECMO in such cases? Because ECMO
Yeah.
is cheaper in India. So what do you suggest regarding ECMO in this
And go
type of case?
proximal, all expanded.
Yeah.
And
So
proximal edge will uphold and will expanded. And the expander index is more than 90%.
Okay, good.
the expansion is great.
So-
I know you're looking at that edge dissection.
Yeah, both places we had a little edge dissection, but I think
Yeah.
based on the OCT criteria, we can still leave it alone.
Yes.
what is criteria?
That one's a little borderline. I think you could probably leave it, but that one's borderline. I don't know. I might put an 8mm stent in that one.
Me too.
It's just because there's so much diffuse disease and the ejection fraction to the coronary flow is a little bit low. I worry a little more about this vessel, so I might put an 8mm stent in.
This is little more than just.
Yeah.
Okay,
2.758.
yeah, 2.758.
See the on angiogram. See if we can see that.
No.
Point that out on the angiogram. We took the picture last. We had the picture.
No, we don't see it. Let me just, we
Certainly
may have
that
to do
LED
another view.
dissection- That LED
Okay,
dissection
Sundai.
you showed was absolutely correct to leave.
Okay, now die.
I think we tend to worry more about those that get turned towards the media rather than just in the intima, unless they're very extensive. And that
Yeah.
one certainly is,
No,
it's
no
not
one.
quite well. It's difficult to tell because of the diffuse disease, but it
Another-
looks like it's approaching the medial layers.
Dr. Samin, at what pressures did you deploy the first stent? In a diffusely diseased vessel, would you deploy at, say, a low pressure and then post-dilate to whatever pressures we want to optimize it?
Yeah,
Because-
yeah, very good point. So our question is, a lot of people will put a small, slightly lower stent compared to the vessel size and then post dilate. Our goal has been there just to use 1:1 and deploy it at 12 to 14 atmosphere and routinely post dilate. The key is, since you're post dilating, deploying is not an issue. And I can tell you, we don't have that metaphor, those tapering stents.
Slow.
So in a vessel from 2.5 to 3.5, you can put a 2.75 and then just deploy at 8 or 10 atmosphere and proximally come with a 3.5 millimeter balloon and expand it. So here, if you see an angiogram, you don't see it truly. but it's at the distal edge.
Right.
Angiographically, if you're
Yeah.
not done, I think we'll be leaving this alone.
But no, but that's the advantage of the OCT. Yeah.
Yeah. We'll do that.
Exactly. And you know, and I don't think you would have done that without the impella. You would have left it alone, and perhaps it would have closed.
Yeah.
So this is the advantage of being able to take your time.
All
We
right.
know that edge dissections are one of the big predictors of stent
1758, right?
thrombosis.
Yes.
Yeah. Yeah. So clearly that with a slight, that about 3 millimeter, that intimal flap, which has not gone to media, but it's still quite significant. Decision was made and recommended by Greg that we should put a stent. So we are doing the stent in that area. LAD was a small one, so that we left alone. And this is just tells you that post-procedure, OCT gave us the help or identify this. These are the rare cases, because question is how many of these flaps will have an acute occlusion, particularly use a strong antiplatelet therapy. Many of these cases we use IV cangrelor and so clearly, but even that is small, that number happens whether 0.5 or 1%, goal should be to not that to have it. And that's what the OCT will help in this particular case. We are putting a second 8 millimeter stent now in the distal edge.
And if it happens, I totally agree with everything you said, Samin. And if it happens in this patient, he may not survive it.
Yeah, that is correct. Yes. But based on the MRI, we had a lot of consultation in this particular case. Everybody believes that his EF should improve. And we actually have seen cases, these type were not really frank amide, multiple vessel, old closure, and
Good,
so
right?
that
Okay,
after
stop.
good intervention, and then EF from 20 goes to 50,
Right.
55.
Good.
We have
Down.
had cases, quite a bit, many cases of that. So I hope this patient will fall
Go
into
up
that category, because he's not a truly
14.
chronic ischemic heart disease patient who has had a multiple MIs and things in the past. This was
Right.
all
Down.
relatively acute in last 1 month.
I totally agree that with this kind of a viability on a PET scan, I'm sure it was a PET scan which showed the viability.
No, actually we did a cardiac MRI. I am on the MRI scan. Yeah.
Ready?
Okay, okay. But he is going to improve definitely.
So, I mean, the contribution of OCT in decision making is more pre-stenting or post-stenting, or
Well, that's a good point. I can tell you from my point of view, imaging is the biggest value of the imaging is post. In rare cases where you are deciding whether I do some more atherectomy or atherectomy and so moderate calcium, whether it's more than that, so then pre-decision making comes. But post, because let's say you put a small stent, it's a 4 millimeter vessel, you put a 3/0 stent. Post will tell you, post dilate to the 4/0. So to me, if I truly, and that's I call it A cube, assess, the lesion basically assessment and acquisition, and then post expansion and post pictures. So key is that truly the real value, of course, it's all multifactorial, but if you take 100%, I would say 90-95% contribution of the good result of the imaging will be based on your post, and others maybe just pre and in between. I'm sure many of our panelists may disagree, but that is what I believe. And of course, maybe I'll ask Anu to make a comment on that in terms of, just to say, our lab, to be very clear, Mount Sinai lab is not a imaging lab. We do imaging in single digits, but we do a lot of physiological. Physiological, between 60 to 70% of our interventions are done physiological guided. The imaging guidance is in single digits here. And many of them, we do it as a protocol and the trial, which many of Orbit FFR and Yellow and all those Dr. Keeney has done. And do you want to make a comment on that? Your post?
Yeah, so I think both, I agree with both Greg as well as what Dr. Sharma was mentioning, that where will you use the most? You got to remember, we all were trained in the absence of intravascular imaging. So our eyes are used as fluoroscopy to assess calcium and also, the lesions. But the current training is such that they need to have more data so that they can make a decision exactly what kind of treatment that they can give to the patient, and there's a best outcome for the patient. And that is why I think pre-imaging will help to understand calcium, the lesion length, the way they want to train themselves. And post is very important in this kind of patients, and in patients who are having a left main, unprotected left main stent, to make sure it is completely opposed.
Right.
If you do pre-imaging, you have so many options to modify the lesion. If you do only post-imaging, your options are greatly limited. So how do you contrast these two issues?
Very good point. So I think to me it's very simple. Very severely calcified, tram track calcium, and I've moderate many of those live sessions, and they want to find out based on the IVUS or so, or OCT that is the calcium. Well, and we know that those really little angulated lesion and tighter, IVUS doesn't even go. So what I have done, you added extra procedural time and so. So I think questionable cases definitely, and very simple is that if you, to me, once we see the angiographic calcium, we know some of them could be just a superficial calcium and so, or that and deep wall calcium. So majority of them that will respond to atherectomy. So clearly, as I mentioned, it's a different threshold. We do about 22 to 25% of our cases PCI using atherectomy. Of that, about 75% rotational, about 20 to 23% orbital, and about 2 to 3% laser. So we have very low threshold. And why? Part of the cases which are referred. So that there for us is not even a question what you should be doing once you have a severely calcified. Now in a moderately calcified like this OM, if you want to do for teaching purposes, then what to do? I would say otherwise I would have done just cutting balloon. Had it not been for this live presentation today, we have done the same what we did without pre-imaging. And then once your lesion has expanded, if not expanded, change it to rota, and then put your science stent, post dilate, and then do the imaging in the end. So that's where it is. I know a lot of people are very gung-ho, or the training can't make a decision without imaging, but again, it's part of the training. I mean, everyone is trained a little differently. There are more than one way, and I can tell you our way, what we do here. And as you know that from the New York State point of view, Mount Sinai lab is the safest lab with the lowest 30-day risk-adjusted mortality for last 22 years.
Dr. Sharma, thank you very much indeed, and to your team. I'm just being asked to remind you that we only have just over 15 minutes left, and we're all keen to hear your keynote lecture as well.
Yes, yes.
I just want to, for the conclusion's sake, the total fluoro time was 27 minutes, including impella insertion. Contrast is 140 cc, and DAPT was, Air Karma was 1.7. Reason I'm talking about this is that New York State is a rule that all of this have to be reported, and if it goes beyond certain numbers, especially if it is Air Karma of more than 5, you got to talk to the patient, and more than 15, we need to report it to the state. So everything is being monitored, how these complex procedures are done. And I think we are going back to the point, the complex procedure. Did Impella help here? I think as the panel discussed, doing the complex procedure faster, quicker, with lower dye can be done with the help of a support when the EF especially is less than, this guy is like in the 20% or so. It really helped.
Beautiful case.
I would like to make a comment here.
Yes.
Yes,
Praveen.
This is a wonderfully done case, and so nicely. I must congratulate Dr. Kinney and Dr. Sharma for this exposition. The last question I want to ask you, are you going to pull out the Impella right now, or you want to keep it for some time?
This will come out now. Amit Huda, who actually did the pre-close and inserted the Impella, is a master for these things. He's the one who's going to remove it. Pablo, our tech, as well as Will, our nurse, Adrian, our nurse, who helped us during this complex procedure. These guys are well trained to do these complex cases. They're weaning it already, and Impella will be coming out. They're going to post-close it, and patient will be in the holding area.
And I just want to give you our data. If I take last 100 patient where we use Impella, we use about 14 kind of Impellas per month. Last 100 patient for high risk Impella, the out of the cath lab, Impella removal is probably 1. Now, some patient with a cardiogenic shock is a different story, but high risk patient is just so rare. Why? Because this gives you time to do good intervention. And that's one of the biggest advantage with the high risk. And I'm talking about the large number of patients, various operators performing this intervention. And since the single access, few of the complications of the impella in the past occurred in the non-access site, non-impella site. Because whatever reason, so we actually had 2 patients in last few years. But since we started using this 14 French CP with a single access, it has been tremendous. So far has been, maybe 60, 70 patients just for that purpose, and had been no complication. But yes, all of them were pre-close, and of course, then we don't take a routinely post-close picture because you can do it. Because it's a single access. But if the dual access, then you definitely should do a good vascular hemostasis, because that is, we learn as more and more that bleeding is a bigger predictor of subsequent bad outcome compared to even some procedural complication of MI.
Yeah. Okay, cool. Shamim sir, I'm just repeating the question. See, since Impella is very expensive in India, we have some experience with ECMO in such cases. What is your say in that? Do you use prophylactic ECMO in such high-risk patients?
Yeah, so
for ECMO, remember you need a venous access also. It's a large bore venous access, large bore arterial access. So now you're exposing the patient to 2 vascular, access. Have we done it in the beginning? We are using the ECL, we call it ECLS for us for elective cases, but primarily right now we are using it for shock patients, and of course for COVID cases who really need it for the pulmonary side, for the pulmonary support. Because of venous and vascular arterial access, we actually do not promote that.
Yeah, but
for elective cases like this.
But I would say that I can hear your point, and that is what we used at Eternal, my hospital in Jaipur, because the cost containment, there is a big difference of 15 lakh rupees versus 2 lakh with the ECMO. So clearly some cases can.
Yeah, Dr. Sharma, that is a very right point which Dr. Selvamani actually discuss
a patient. So that is why we have had this combo, and then all the access have been used. Now we have to go radial to do the procedure for this patient. So we have gone through this kind of situation. That is why we moved away from ECMO, unless the situation that I mentioned, true cardiogenic shock, where nowadays ECLS is being done even in the ER, or patients who are COVID and who have pulmonary issues. Yeah.
So yeah, Dr. Kini, I think that was a very good point. And in fact, we have used Dr. Selvamani in many cases, a combination of ECMO and Impella. And there were some cases actually where we were doing, a high risk intervention, with the Impella. And if the patient's BP starts dropping, that is the time when many times you have to use ECMO at that stage. You finish the procedure quickly, the BP is still going down because Impella may not be able to increase the pressures at that stage. So then you use the ECMO, maintain the ECMO for some time, and then bring it out.
You really, I think, need to move on. Dr. Sharma, if you're going to give your talk, we're running
just a few minutes. Yeah, I think we had a lot of discussion. Yeah. What is the exact time now? What's the time now? 10:31. So I think we've finished our time, but I just wanted to go to the slide only. Tell the main screen slide, just few things. We wanted to show some about the app and just completing this case. Only you have the app thing. So just wanted to complete what we did. We always go through our appropriateness in terms of what this particular case was with a syntax score and STS score of 5.8, and then appropriate grid in this particular case because of 3 is the M, but clearly after hard team discussion become A. So now you want to show some apps, wanted to update the latest one, which we have, the Bifurcate app, the Calcific app, Octade app. So many of them, which with a scientific basis of these uploads, which are very educational, which Dr. Kini has developed in last few years, and particularly this Calcificate app.
Yeah, show mine.
So you wanted to show something different. Just wanted to say last slide from my side that this is what we use usually with a combination of high risk and LVEF and lesion morphology that clearly is like this particular patient with a high syntax score where there's no option. You are it. There's no surgical backup because surgeons already have turned down the case. So those are the cases you need to do, which in the middle category in the red, appropriate, adequate, correct intervention, and that on the long run is going to help these patients in terms of their decrease death, MI, and revascularization, that improve prognosis. That is what we are hoping. And that will be the major trial which Dr. Stone, as we mentioned, Protect 4 will answer that ultimate question in these cases. Now,
we just have a few minutes, right?
Yeah.
Yeah, change.
Yeah.
So this, they are trying to do the closure. Yeah, the guide is out, and then they're going to do the closure. It's very bad. Ready? Yeah, so for this particular case, I think we have this, all the apps that we are going to talk, but calcificate is something which we have never discussed. Keep going.
Yeah.
Oh. So in this case, remember it was a non-bifurcation lesion, and we knew that angiographically was moderate. And how did we confirm? By doing intracoronary imaging. This is how, in the app itself, it will describe various kind of calcium. So if people don't know how it looks, what OCT looks like, there is an app for OCT called Octade. You can always download that and see. But otherwise, this is exactly what we saw. This is only one quadrant, a little bit more than a quadrant, to give us idea of how it looks like. So if it's moderate calcium, what we will do is the same. We will do the atherectomy. If it is a severe calcium, then we can do other things. So now, if you go to atherectomy, this is what it will show. There are 3 atherectomies available when we made this app, which was rotational atherectomy, orbital, or XML laser. So this is exactly where the, it's a brief description of each device, very short, concise, so people will know what are the indication, when to use each of these devices, and also techniques how to use these devices on the things. Now this is, I think many people during the live case always ask us, why do you use OA or RA? This is a brief, concise way of saying when to use RA. Very important is aorto-osteal lesion when there is angulation, and especially if you need a larger burr and subtotal or a total occlusion that you crossed, RA is a better, because you see it's conical, and most of the diamond chips is in the front of the RA, so it is easier to cross this lesion. And of course, for ISR under expanded stent, OA is not approved. For the rest of the things, OA is very good, especially for hemodynamic instability and the current generation who want to do everything fast. So that's much easier to use your OA. Now, if you want to learn more about the apps, we have cardiologyapps.com. It's a website. All these apps are free to be downloaded via the App Store or the Google Play. And what we just released is what's called as a Complicate. This is a web app. It's just a website where we have over 55 cases of various complications that happen. So atherectomy, what are the complications of atherectomy? And then we are showing some case examples, all the cases. These are the cases done in Mount Sinai, the complications that they have had, how we treated them. And this is a learning point of every case by case, how you treat these complications. This is a web app where you can see these are the various apps that are out there. And STEMI app is the one that will be coming soon. And I just want to show you this one, which is the Bifurcate 3D. The bifurcation cases, again, press it. Oh, back and back. Okay. So bifurcate 3D. So bifurcation, I am telling you, is 3 things interventionalists always want to learn. How do we do a bifurcation? How do we take care of calcific lesion? And how do we do CTOs? So every live case, I think people want to learn more about bifurcation. So this is a 3D animated app that will be coming out soon. Say step by step, all the various techniques and where to use these techniques, which are decay crush, mini crush, culotte, and of course, everybody's favorite provisional technique. And if something goes wrong during provisional technique, how do you bail out? So this is a 3D animation called Bifurcate 3D, will be coming out soon.
With that note, Dr. Nick Vester, Dr. Savlamani, we conclude here because you have another 1 hour of marathon session. And I really thanks Abbott Pharmaceutical, Abbott Vascular Incorporation to give us this opportunity and to reach our Indian colleagues Just to say, our CCC Live gets about 12,000 hits per month. About 75% is from USA. The second one is India, which is about 14-15%. And really, I continue to thank and continue our educational mission, teaching latest tip and tricks to become the safer and good operator for complex cases.
Thank you very much indeed, Dr. Sharma. Thank you very much indeed, Dr. Kinney. Fabulous case. Really good to see those educational opportunities that are available, free to download. And I'm sure we would encourage everyone to improve their practice by doing so. So I think just before we close the session, we're going to flip apparently directly to the next session. Thank you very much indeed to you and your lab staff, and of course the patient. Thank you very much indeed to all the speakers and the expert panel. We hope you've enjoyed this session and it's been educational for you. Thank you very much indeed for joining us.
Good.
Yeah. Thank you very much, sir. We had a very good learning live case here. And this is not the first time. We have been learning it from you for so many decades now. And really, it was very useful. And at the end of the session, I would like to thank all our international speakers, Dr. Greg Stone, for his excellent talk and moderation and discussion which he took through. We learned a lot from you, sir. And Dr. Shripal Bangalore for his excellent talk. And of course, I request Dr. Samim to continue as an expert panel in the box one today. And very special thanks to Dr. Nick West, who is a DVP Medical Affairs and Chief Medical Officer for Abbott Vascular. Thank you very much, sir.